Next, I call upon Dr. Anju Kuriakose, who will be presenting on resolving the IRVAN conundrum.
So good afternoon to one and all present here. I am going to present a case of a 28-year-old man presented with blurred vision for 2 weeks. He is not giving any history of headache or vomiting, no history of trauma, no comorbidities or not on any medication. On examination, his vision was 6/6, both eyes, anterior segment with within normal limits, and IOP was within normal limits. Next is fundus examination of the right eye, showed cleared media, tortuous vessels over the disc, and exudates paranasally with peripheral sheathing of vessels. Fundus of the left eye showed similarly clear media with tortuous vessels noted over the disc with exudates in the parafoveal region with a macroaneurysm inferior to the fovea. So this is a montage picture showing peripheral sheathing of vessels in all 4 quadrants in both eyes. So this is an OCT picture of the right eye showing normal retinal layers, and octa picture of the right eye disc showing disc aneurysms, and octa picture of the macula showing normal FAZ. So left eye OCT macula showing normal retinal vessels. This is the OCT picture corresponding to the macroaneurysm, which is showing diffuse thickening of the retinal layers with hyperreflectivity with backshadowing suggestive of exudates. This is an octa picture showing disc aneurysms, and OCT octa picture of macula showing normal FAZ. This is the octa picture corresponding that macroaneurysm in his left eye. So with this was the first examination. With the examination and the history, we have come to a differential diagnosis of optic disc granuloma with vasculitis, VHL disease, retinal artery macroaneurysm, Coates disease, or IRVAN. So we went for the basic workup with uveitic workup with chest x-ray, ultrasound abdomen, since we are seeing macroaneurysms, and carotid Doppler, which was found to be normal. Next visit was his FFA, which showed right eye showed the area of hyperfluorescence over the disc, which was increasing in the late stage with diffuse leakage. This is the left eye fluorescent angiography showing again the diffuse leakage in the late stage along with the leakage from the macroaneurysm. This is a montage picture showing extensive CNP areas in all 4 quadrants. So we started him on oral steroids, and after he was followed up after 15 days with no complaints, but after 3 weeks he came with complaints of seeing black spots in his left eye. Even at that visit he had vision 6/6, anterior segment normal, and IOP was also within normal limits. This was a picture at that time. Right eye was similar, but left eye showed opacification of the retina in the inferior parafoveal region close to the macroaneurysm, which was increasing in size. This was the OCT at that time, which shows hyperreflectivity of the middle layers near the parafoveal region, suggestive of a PAM lesion. As you can see, this is corresponding OCT taken corresponding to the macroaneurysm, which has increased in size. So this is the fundus picture is the first visit, and this is the fundus picture in the second visit. We can clearly say there is opacification of the retina with the increase in the macroaneurysm size. So this was the size of the aneurysm in the first visit, 333, and the second visit is 586. So this was the OCT in the first visit and the OCT in the second visit. And this is the OCT of the aneurysm in the first visit and second visit. In the second visit, we can see the microaneurysm size has increased with diffuse thickening of the retina. This is an octa corresponding to the second visit, which is showing the enlargement of the FAZ zone, which is corresponding to the PAM lesion. So at that time, we have done the HFA and neurological workup. Based on the workup and the literature review, he was diagnosed to have IRVAN, idiopathic retinal vasculitis, aneurysm, and neuroretinitis. In view of increasing size of aneurysm and PAM in OCT, intravitreal anti-VEGF was given, followed by an FFA-guided PRP was done in both of us eyes. 1 month post anti-VEGF, we can see the gradual resolution of hyperreflective lesion along with the progressive thinning of the OPL and IL, partial collapse of overlying retinal lesions leading to irregular foveal nomenclature. So this is the size of the aneurysm with the corresponding OCT. This is first visit and this is second visit, the PAM lesion. This is third visit, a post injection. So this is a post PRP picture. FFA guided PRP was done, and this is 6 months follow up in which we can see the aneurysm has totally disappeared from the left eye. The OCT of the 6 months follow up, resolution of hyper-reflective lesion with severe thinning of OPL. In this picture, we can see there is no aneurysm noted. This is the first visit, second visit, third, and fourth visit. So what is new about this case is paracentral acute middle maculopathy, that is PAM with IRVAN, was reported by us in the literature to the best of our knowledge. Vascular occlusion might result from disrupted blood flow associated with the macroaneurysm. In our case, dynamic change in the size of the aneurysm was probably led to the localized vascular compression causing the PAM. So my questions are, how will the oral steroids alter the clinical picture without the systemic treatment? Because we had started the oral steroids before the FFA, after the initial workup. Yes, like we haven't started any other treatment. We didn't do any PRP, FFA. Before starting the FFA, we had done the we had started the oral steroid. Will that alter the clinical picture?
Definitely alter the clinical picture because IRVAN is retinal vasculitis. So there is an inflammatory component there that has caused all these findings. So that inflammation is going to come down with your oral steroids. So did the increase in the aneurysm size occur after you tapered the steroids?
No, when he was on tapering of steroids after 3 weeks.
Okay, because IRVAN, IRVAN is a diagnosis of exclusion. You cannot diagnose IRVAN in this patient without ruling out all the other causes of vasculitis, especially sarcoidosis and tuberculosis. Because the secondary aneurysm formation that has occurred here can occur in any vasculitis. So we cannot, idiopathic retinal vasculitis, for you to make it that idiopathic, you have to do the full uveitic workup and then put the patient, if needed, on steroid and immunosuppression. Yeah, our topical treatment, our local treatment will be only adjunct to the systemic treatment, especially since both eyes are involved. No, only one eye.
One eye, aneurysm was there only in one eye.
Only in one eye, okay.
So
your other differential diagnosis will be adult coats also. You can get multiple aneurysms in adult coats. That's another list. Did you have any vitritis? I thought in one OCT, what was his floaters because of vitreous hemorrhage?
No, he was seeing only black spot, like one scotoma.
One scotoma.
Scotoma.
Okay. One of the OCTs is showing a little bit of a vitreous dot just over that aneurysm. Just go back to your OCT, I'll show you. Previous, one more before. No, this is the beginning, no?
This is the first, this one.
Can you see? Yes.
Yes.
There is a small vitreous cloud-like thing there over. So there is inflammation there. Okay, it's not a very common disease. Does anybody have any questions?
I have discussion.
You have one more. Oh, discussion. Okay, go ahead.
So second question was, given the extensive CNP areas and peripheral sheathing of vessels, should we further do a vasculitic workup?
The vasculitic workup should be done in the beginning. You cannot give a diagnosis of IRVAN before you do the vasculitic workup. So the CNP areas have nothing to do with it. CNP areas will be there in any vasculitis. If it is an occlusive vasculitis, has to be treated with PRP.
So after seeing that PAM lesion, should we treat with anti-VEGF right away, or should we observe? Or is observation a reasonable first approach?
Not observation. I would have given the patient systemic steroid plus immunosuppression and then watched what is happening to the microaneurysm, given PRP if this thing. Anti-VEGF to reduce, even in macroaneurysm, anti-VEGF is not really indicated. So I wouldn't have jumped to anti-VEGF, but you've got a good result. So
So, discussion, it was first described by Chang et al. After a series of cases, isolated retinal vascular disease that can progress rapidly to severe vision loss due to ischemic changes. So, it includes diagnostic criteria, which includes major and minor criteria. Major is retinal vasculitis, aneurysmal dilatation, neuroretinitis, and minor criteria includes peripheral capillary non-perfusion areas, retinal neovascularization, and macular exudation. So, new thing has come. Is there a true neuroretinitis in IRVAN? Neuroretinitis has been considered as a prominent feature in IRVAN, diagnosed with the late optic disc staining on FFA. However, patients with IRVAN syndrome will not usually doesn't present with an alteration in the optic function, visual function, consistent with an optic neuropathy. So the typical stellate exudate maculopathy seen in IRVAN is primarily caused by the leakage from the retinal arteriolar aneurysms at or near the optic disc, which could be misinterpreted as a feature of neuroretinitis. From that study, they have concluded there is no clinical evidence of true neuroretinitis at any disease stage in patients with IRVAN syndrome. So they have proposed a better acronym, that is IRVARE, that is idiopathic retinal vasculitis aneurysm and retinal exudates is proposed to better characterize the syndrome. So multiple imaging modalities are used. OCTA can be used as a complementary tool to FFA in the diagnosis and to assess the progression. So what is this middle maculopathy? Paracentral middle maculopathy is deep capillary ischemia in the acute phase can be recognized by a characteristic hyperreflective lesion at the layer of INL referred to as paracentral acute middle maculopathy. Thank you.